Hello, I'm Ronald Day, Associate Vice President of the David Rothenberg Center for Public Policy, and welcome to Both Sides of the Bars, a discussion-driven show that examines the criminal justice system from various perspectives, including from those most impacted by the criminal justice system. We discuss critical questions about how the current system works, its intersections with social justice, and highlight the efforts that are being made to improve the lives of everyone that is affected by it. We ask you, the viewer, to spread the word about Both Sides of the Bars and to share your comments with us on Twitter at The Fortune Society. So today we're going to be talking about a very controversial issue, mental health, and I have with us two guests, Jessica Glass and Brett Stewart. Thank you for joining us on Both Sides of the Bars. We have two fantastic guests with us, and we're really excited to have you here.
Thank you.
All right, so again, mental health, mental illness, a really complicated and complex issue. But let me just put a little bit of information out there about my guests. So Jessica Glass is an LCSW and is currently the clinical director for the Better Living Center at the Fortune Society. She is also an adjunct professor at Fordham University, where she teaches clinical practice in the graduate school program. Ms. Glass brings over 10 years of management experience to working in outpatient clinic settings, serving disadvantaged populations. Through her experience managing psychiatrists, clinical supervisors, direct social work staff, and an administrative team, Ms. Glass notes that she learned the impact that policies and administration have on providing client-centered quality services. Through participation in numerous city and state-funded projects, she has also learned that the connection of evidence-based practices has the greatest effect in formulating and establishing sound policies which benefit our clientele. And also with us, Brett again. Thank you for joining us, Brett. So Brett Stewart was born in the Bronx and has spent his life there. Brett considers himself a person that is cool, calm, and collected. He has been a client at the Fortune Society for just over a year, coming here on his own shortly after a run-in with the criminal justice system. Not only is Brett a client in the Better Living Center, but he is enrolled in our education program, working on earning his high school equivalency. And he has a three-year-old daughter that he spoke very passionately and fondly about, and her name is Zatara. Thank you for sharing that information. So let's talk about this issue, and I want to start with you, Jessica. I mean, we know that mental illness is, again, something that is really complicated, and it's something that folks who deal with the issue face a ton of discrimination, a ton of stigma. There was a New York Times article that came out recently that talked about how a lot of people with mental illness are often warehoused in jails, and so I want you to kind of like frame the issue for us and tell the audience what we do in the Better Living Center at the Fortune Society to support people who have mental health issues.
Okay, so, and I think Brett will actually be able to speak to this a little bit afterwards, yes. Possibly. You know, or you can jump in. So the Better Living Center, I think, is one of the unique clinics in New York in that it's housed in the Fortune Society, which works with individuals that are formerly incarcerated or to avoid incarceration. Yes. So the majority of our referrals come from either Rikers Island or people that are avoiding incarceration sentences. And then a lot of referrals also come from in-house. So when clients are being referred by parole or part of their mandated sentences that they have to attend a GED program or they have to attend an education program leading up to GED or an employment program, and they go into those programs and they haven't had much experience with it, and they are acting out in terms of they are not able to get along with their peers, they are sent to the mental health clinic. So we're able to intercept and be a source of support right then and there, instead of having to go to another location and work with people that have never worked with individuals that have faced the criminal justice system. So when they're acting out, other places might turn them away right then and there and not be willing to work with them. Whereas the Better Living Center takes a very warm approach to that. And and we will not turn them away. And we will work with them, and we will let them vent and have a session with them right there in crisis mode. And after they're venting, we'll still offer support. We'll have a session with them. We'll engage them in treatment and give them those multiple chances that they need to succeed instead of rejecting them, which is something that I think that they've faced their whole lives. And I think giving them multiple chances is what builds that engagement and leads to success, as opposed to them facing multiple forms of rejection and then just ending up another case in the system where they don't feel that sense of trust and they don't feel a sense of respect or dignity or that anybody believes in them. And another chance at not being able to, not having somebody believe where they don't succeed.
Thank you for sharing that. And Brett, so you are someone who's in the Better Living Center now. Can you tell us about your experience?
Well, my experience with them personally, myself, was kind of great. Mm-hmm. At first, it was I didn't want to be perceived or judged of my actions or seen as a bad person.
Yes.
But me being around or introduced to them people was helped me cope with my emotions, my feelings, and how I comprehend or see the world or society. And they helped me grasp my feelings without being judged or put down or any kind of feeling like acceptance, to show like right from wrong, or to show that it is help, that you can be better, or that there's nothing actually wrong with you. Maybe you've been through something that reflects on your actions. So I could say my experience has been great, wonderful. And the people that there is wonderful. Sum it up in one word, it's wonderful.
Okay. And so you're also in an education program now.
Yes.
Right? How has that experience been for you?
That's good too, because it's jotted my memory of the past education that I have. Yeah. So I won't feel like, when we label as retarded or stupid or feel down. And the people that work there is patient with you. They work with you and understand where you're coming from and help you in the aspect or the areas that you need help in. So to further yourself, wherever way you're trying to, or path you take in life, they helping you. So it's kind of cool. The word you want to use for all around is cool.
Thank you. Appreciate you, Brett, sharing that. So Jessica, I want to turn back to you now and ask, can you discuss how oppressed populations can be misdiagnosed due to the symptoms of psychosocial stresses, particularly those being misinterpreted? Because we know that, a lot of times folk are out there and they're being diagnosed and oftentimes forced sometimes into treatment and or required to take medication, and then sometimes ending up in jail, and it's becoming like a vicious cycle. So can you speak to how how is this misdiagnosis happening so frequently?
A lot of our clients, especially the ones that have come out of incarceration, either Rikers or jail, come to us with the popular diagnosis of either bipolar or more popular schizophrenia. So a lot of the clients have been in solitary confinement. And one of the ways that they learn to cope is by talking to themselves. So they come out and they don't have the cognitive skills a lot of the times as well because of poor education, poverty, malnutrition. And as a coping skill, they'll try to describe what that's like to somebody in other facilities. And they've been told that they have the diagnosis of schizophrenia. Not even that they have the diagnosis, they've just been told they're a schizophrenic, which is worse. You're a schizophrenic, not you have the diagnosis of schizophrenia. So as Brett was talking about, the stigmatized of you're a schizophrenic. So they don't explore with them that it's a coping mechanism from being in solitary confinement for really extensive periods of time, that's how they've learned to cope, by talking to themselves. So when they come out, and our doctors examine them and do a mental status exam, they look into that a little bit deeper, and that's just a coping mechanism for post-traumatic stress disorder. So we diagnose it properly, and we don't give over-medication to say you're having a hallucination and you're talking to yourself and you're responding to internal stimuli. We say it's a coping mechanism, and probably a good one that got you through
that experience.
That experience in being in solitary confinement, and even recognize it as a strength rather than further stigmatize them and say it's a symptom of schizophrenia. And if it was, that's fine too. We can work with that as well. But more often than not, it's not. So we'll say it's probably a symptom of post-traumatic stress disorder, and we can do psychoeducation, and we can do psychotherapy, and figure out another way to deal with post-traumatic stress that's not necessarily medication-based, where people might feel like they're losing more control and more of themselves. And if medication is a route that we're going to take, we don't have to take it right away. We can build trust before we're going to take that route. It doesn't have to be medication instantly, and it doesn't have to be medication at all. So we'll look for the correct diagnosis. Bipolar is also a diagnosis that's given right away, and clients might be having mood swings related to having been incarcerated and having been in violent situations their whole life, culminating with being incarcerated and having to fend for themselves and having to be in violent situations where they have to protect themselves. So that's not a proper diagnosis either, because it's a normal reaction to the situation they're in. So the proper diagnosis would probably be adjustment disorder with anxiety or adjustment disorder with depression, as opposed to bipolar disorder, because it's not a chemical imbalance or reaction. It's an appropriate reaction to the environment that they're trying to defend themselves from. Not that bipolar would be something that we would stigmatize either, but it's just not an appropriate diagnosis given the environment that they're in.
That's a great answer, and I'd like to come back to that in association with PTSD. But Brett, I wanted to ask you, what has been the biggest challenge for you after your diagnosis? And I know you mentioned that being accepted and not judged is something that was important for you.
Yeah, not being judged and being accepted for your wrongdoing or your past, not holding on to it, not feeling like, oh, since I did something or I've been through something, that I'm not accepted, or I'm less of a human, a man, per se. That you can take other steps, that it's not the end of the world, it's not over. That you don't have to dwell on it. You can take courses of actions or change your life for a better way, right of passage. Okay,
thank you. So, and Jessica, I think that was really insightful what you said a second ago about the misdiagnosis, and particularly with regards to the adjustment disorder, because it's more likely assumed that if someone is inside a cell, solitary confinement, and a person is trying to cope with that really negative and sometimes really abhorrent experience, that people have to come up with ways to deal with it. So, what about PTSD? Because we know that a substantial number of individuals are also suffering from PTSD who also have been involved in the criminal justice system. So what would you say, about it? Do you see a lot of that in the practice?
I would say at least 70% of our clients have PTSD, if not more. I think more of them probably have it, but they don't identify the symptoms that way, and are a little more guarded in describing them. So if they don't recognize that they have them and won't admit to them, we can't say that they have them. We can't attribute it. So probably even higher than 70%, but at least 70% are even acknowledge what this, or answer yes to the questions of the symptoms. They still might not identify it that way. But for example, when we're doing biopsychosocial assessments, which is part of the intake where we ask about all of their background and their environment. We recently had an individual who had been shot and paralyzed from the waist down. He was a bystander. And when we were trying to identify that and help him understand that as possibly a PTSD diagnosis, he was insistent that that was a normal experience, that multiple individuals in his neighborhood had that, and he quote unquote said it is what it is, and it was just a normal experience in his neighborhood, and he didn't identify it as trauma.
Wow.
So it's just the exposure is so common that even though it is PTSD, because he would describe waking up in the middle of the night and having the flashbacks and having all of the symptoms, he still didn't cognitively recognize it as PTSD.
So it's so pervasive to a certain extent that the abnormal becomes the normal in certain community. So yeah, thanks. So
when it manifests as anger, it gets diagnosed as bipolar because the trauma is not treated. So if you treat the trauma, I think the bipolar diagnoses and the schizophrenia diagnoses would be a lot lower. But I think it's just a knee-jerk reaction to say schizophrenia, bipolar, because it's just easier to say that, medicate that, and that be the explanation than to work through all of the trauma.
And then in certain communities, there's trauma after trauma, on top of trauma, on top of trauma. So, Brett, what I wanted to ask you next is, mental illness doesn't discriminate, right? And we know that still a lot of people with mental illness suffer from deep discrimination and deep stigma. So I wanted to ask you, what has been your experience with the stigma and with discrimination?
Well, coming up, it sort of starts in the home. You come up and it gets passed down that you have to act a certain way. But when you step out that door, you have to change up. You have to act another certain way. So it's like you always faced with the burdens of walking right and walking this type of way. It's like the judge. It's like a thin line to what is right from wrong. And sometimes it's hard weaving through that line, that you need another outlook besides family members or associates. You need somebody else on the other side that can show you or tell you some way that you can grasp it and show and think about it yourself and how to go about the way you want to choose or how you want to go about things.
Sure. Yeah, and we know that a lot of people that are watching this show may themselves have had issues with mental illness or mental challenges, and people are afraid to talk about it. People have, if not themselves, they have family members or they have friends, and so what do we offer to people who have that as a challenge, and what do we offer to society about dealing in addressing the stigma of mental illness? Jessica, let me ask you first, and then I'll go.
In the clinic, you mean?
I'm talking about as a society, because there's so much discrimination and so much stigma. What is it that you would offer as a clinician to address and to minimize the chances and the likelihood that someone is going to have to face that stigma? What do we need to do as a society?
I mean, I think we need, it's a great question. I think we need stronger role models and stronger support from an early age. I think we need better resources for children and adolescents to go to. I think there needs to be more after-school programs or more structure for children and adolescents. I just think they need constant access to that from a very young age, and it to be reinforced in a positive way. And for families and mothers and fathers to receive that kind of support.
Yeah, support is necessary. And so, Brett, what about you? How do you think society would be best served by addressing the issue of stigma? I mean, what would you want to offer to all of us?
I say be more open-minded, be more conscious of others, be open-minded to accept criticism and to know your trial and error, so for you can cope with it and know how to go about it and be better at your actions, be more conscious, be more conservative. It comes down to morals and goals, sometimes laws, you know what I mean? Like discipline, for your actions, like for the stuff you do, you have to take acceptance and have to take responsibility. I say it starts in the home, then it reach out to society. But I say it starts in the home first. Be more open-minded, be more understanding, more conscious of others and yourself.
Yeah, I like that answer. We definitely need to be more understanding.
Yeah, more understanding about
as a society.
People's feelings and emotions. We are humans. We're not made to be robots. Not yet. Not yet. Technology is working, but
and so there's the stigma of just having the mental illness, but then it's compounded by criminal justice system involvement. And so again, more layers. So what are the best practices for working with people who have mental illness who also have criminal justice system involvement?
That when somebody from the criminal justice, somebody with a criminal justice background is seeking help to accept them and give them help, and not assume that because they have a criminal justice background that they require more intensive care than somebody without a criminal justice background. I hear that a lot from the clients. We get clients that travel 2.5 hours from other boroughs because they can't find somebody to help them because they've been told that they need a special kind of help. There's not a special kind of help that they need. They need help just like anybody else needs help. So they need a warm, welcoming environment, especially if they're seeking the help and they want the help. There's no reason not to offer it. They need the same kind of psychotherapy that anybody else would need. So offering a warm environment, weekly psychotherapy, offering psychiatry visits, not mandating therapy, working with clients to figure out what kind of medication they want, if they need it, to sleep or stir appetite, things like that. Same as any other population would need it. Offering group therapy, introduction to peers, and support. Developing a social support network, I think, is helpful for clients. And also providing other kinds of supports outside of the therapeutic dynamic, not necessarily just within the therapeutic frame. I often refer clients to outside resources. It doesn't just have to be like the therapeutic alliance that they get help from. They often, clients come and they have all other kinds of interests, and they can build upon those kind of resources as well. So there's a lot of things out there, especially in New York, that they can clients can take advantage of. And I refer them to those kind of resources as well, simply by doing a search online. But I think the biggest impediment that clients suffer, is that they go and they seek help and they can be honest and forthcoming and say they have a criminal justice history, and they're immediately turned away and told that they need a more intensive level of care, which doesn't exist, which is the first problem. And then the second problem being that they're turned away, and I think that initial rejection to seeking help is one of several rejections that they've seen over a lifetime, and once they get turned away, they're not going to come back a second time. So you've turned away somebody that's seeking help, and that's counter to the ethics of social work.
Exactly, and I'm sure that it exacerbates the problem because, as you said, people need services. Mm-hmm. And you mentioned, Brett, that you came to a place like the Fortune Society, and there were comprehensive services that were offered there. And how did you come to Fortune? And you also spoke. What has your experience been like in connecting to those additional services?
Say it again.
How did you come to Fortune first?
Having a realization of like being real with self. Okay. Being real with self. Start with self.
And who referred you to DLC?
Federal Defenders of New York.
Federal Defenders of New York referred you.
Showed me, refer me to, show me a way. It's a path that I didn't think, that I didn't have to accept that it's over, or that that's it, or what I'm feeling is not what's actually happening, or that I can't change, that I'm not that type of person, or I could seek a different route. So, yeah.
And the other services, was it a smooth process in going from one service to the next?
It was a smooth process, because everything I was looking for was right there. It was right in that vicinity. I didn't have to bounce around. I have to just take one thing here and then address something else somewhere else with travel and going of that sort. I could get everything in one environment, in a cool environment, not aggressive, but not too lenient either, you know what I mean? To where you get too comfortable.
Yeah.
But they make you comfortable. Maggie?
Yeah,
to the education program?
Was it Maggie? Or was it Deborah? Because Deborah no longer with us no more. Deborah Griffin.
Okay. Well, that's good. I mean, we just want to, because you talked before about how important it was for you to be connected to other services, particularly if they are, in close proximity. You wanted to be able to go right into the same building, for example, and receive those services.
I didn't want to run around
the city. Go from the Bronx to Manhattan to Queens.
And it's great too, because if somebody's having a stressful day in education or in employment, then they can come upstairs, see their therapist, go get lunch, come back, see their therapist again later. And if their therapist is busy, I have a small caseload. I'm the director, but I keep a small caseload. Then they can come and see me if the therapist is busy. There's like always somebody around. So it's not like they don't have to like leave, get a Metro card, go travel in the subway. It's like everything's in-house.
And just, we have just a couple of minutes left. How do people generally get referred to the Better Living Center?
I mean, we have no catchment area, so anybody could get referred from any organization. So they get referred from another organization, or they get referred internally from any one of our programs. But Rikers will make a referral. Any community-based organization will make a referral. Multiple organizations make referrals to us.
Okay, so people from upstate correctional facilities can come as well once they're released?
Yes.
Okay, housing programs,
everybody.
whatever. Everyone can make referrals. Okay.
And we get a lot of referrals from places that say they can't treat them because they need this higher level of care. So.
And when they say that, well, we only have a short time left, but do you speak to them about that issue?
I do, but I want them to come to us because I know we'll provide good care. So, so we take them.
Okay, good. So I do want to share that the Fortune Society is going to be hosting a Twitter chat on mental health on November 10th from 8 to 9 o'clock Eastern Standard Time. And the hashtag is No Shadows, and the title is Out of the Shadows, Addressing the Stigma of Mental Illness. So with that, I want to conclude this show, and I want to thank you, Jessica, for being on today. It was great to have you, and Brett, especially, thank you, because we know about how difficult it is for people to come and to be willing to speak about, issues that they've had and access and treatment and so forth. So thank you.
And I want to thank y'all, too, for allowing me to be here and allowing me to have a voice and to even feel.
No, it's our pleasure. Thank you.
Thank you so much.
So thank you to Jessica and Brett Stewart for joining us on both sides of the bars today, and thank you in TV Land for joining us as well. If you're interested in finding out more about the Fortune Society, please check us out on the web at fortunesociety.org or on Facebook by typing in the Fortune Society. This is Ronald Day as we critically look at both sides of the bars.